Dear students, welcome to this virtual lecture of 319, week 5. The usual disclaimer, these are the lecture slides and not the examination slides. I have a different virtual lecture available for all the examination slides. So let's start with some interesting changes. So edema. So how do we define edema? Edema is the accumulation of a fluid either within the interstitium of an organ, or in some cases it can be also seen inside the cells. But in most cases edema accumulates in the interstitium. There are many different pathologic processes which can lead to edema. It can be either due to venostasis or can be due to inflammation. These are the most important ones. Once again, I suggest you to read up what we have in the theoretical part in the seminars, because here I will be concentrating on the morphological changes. So let's start with the lung. So lung is an organ frequently affected by edema, which is important for the patient. Here the edema is usually caused either by chronic heart failure of the left side mostly, or due to inflammation. In the case of heart failure, edema is usually bilateral and can also lead to fluidothorax formation when you have accumulation of fluid within the pleural cavity. In pneumonia, which is usually a one-sided process, you have edema only in one half of the lung and around the focus of pneumonia. You can see this difference very well on simple chest x-rays or on a CT scan. So you might say, wait, edema, that is accumulation within the interstitium. But here, if I zoom in closer, I see that the fluid is within the alveolar spaces. You see here this eosinophilic, slightly bubbly fluid, slightly eosinophilic. It contains some proteins, some fibrin sometimes. And in this case, this edema is due to heart failure, so there's not a lot of inflammation at all. You can see that the edema fluid is inside the alveolar spaces and within the bronchus as well to some extent. So this patient had probably acute dyspnoea, and this is a manifestation of end-stage heart failure. So you ask, okay, so this is so edema, wait, but you said edema that is in the interstitium. Well, it started in the interstitium, but what happened is that the fluid left the interstitium and it got basically pushed out into the extracellular space. So what we have here is a transsudate. So edema is within the, well, basically within the septa. There was some edema accumulation, but all the edema fluid turned into transsudate, and it found its way into the extracellular space. So whenever there is some kind of process leading to edema, so either this venostasis or acute inflammation, you can get exudate or transsudate. So please learn the difference between exudate and transsudate. You can read about this in the theoretical part of our lectures, so please give some time to it and learn the differences, because we will be talking about exudate and transsudate a lot. So in this case, this is transsudate because it's not linked to inflammation, but it's linked to chronic venostasis due to heart failure. So the edema fluid got produced in large amounts, and this patient will cough up like a pinkish foamy sputum due to this, and the patient will be in acute distress because the patient will be dyspnoic. You see that a lot of alveoli are full of this fluid. The alveoli that are full of fluid, they will not be able to exchange gases. You can see this, as I've already told you, on a chest x-ray, but you can also feel out the edema if it's really heavy with percussion with your fingers. This is a very old school method, don't forget about it. We live in an era where people are starting to neglect proper physical workups on the patient, but you should be able to examine the patient physically. And also you can hear this with a stethoscope. So what you hear are crackles, the pops as the alveoli are collapsing and opening up. So in the area which is affected by edema in the lung, where you have all this transudate within the alveolar spaces, or exudate if you have pneumonia, then the percussion will be duller, less airy, and the breathing sounds will be lighter, but you will hear the popping of the alveoli that are opening up when the patient is breathing in. So you should be able to find the focus of pneumonia, and then you can see it on the chest x-ray whether you were right or not. But these auscultations would be part of every physical examination, so please don't forget about it. This was edema. Remember, there's difference between exudate and transudate that you should learn about. And we can move on to the next slide. So brown induration of the lung or pulmonary hemosiderosis, I have already talked about it once in the previous lecture, so for some reason it's in this lecture as well, so we might just go back and talk about it a bit more. Since it's an intimate connection with chronic heart failure, so this case is very heavy. So here we see once again the similar site of edema within the alveoli, but here additionally, besides the edema fluid, we have two more things. First thing, erythrocytes, lots of erythrocytes. So this patient already had very heavy heart failure. As I've told you, if you have a chronic venostasis within the lung, then the erythrocytes get pushed through the capillary wall into the alveolar spaces. So here you see that there was a chronic exacerbation, so like an antephinem worsening, and this resulted in a lot of erythrocytes finding their way into the alveolar spaces. There are also some post-mortem changes additionally. So when the person dies, the gravity works with the blood as well, so the blood accumulates, the blood pools in areas which are the lowest. So the basal aspects of the lung parenchyma, especially of the lower lobe, tends to be engorged with blood. So this is a mixture of antephinem bleeding into the alveolar spaces plus the postmortem change of hypostasis. But there's also a sign of chronicity, so there was chronic bleeding into the alveoli, because here you see a lot of macrophages which contain this very coarse brown pigment, hemosiderin. You might recall from the previous lecture. And you also have hemosiderin-laden macrophages within the bronchial lumen. Here's the bronchial epithelium, here's the bronchial muscularis. So this is probably a bronchiole, as I can tell, because I see no cartilage. And within the lumen of the bronchiole you see blood, you see mucus, and you see a lot of siderophagy. So this person was coughing up blood-filled sputum. So this is a sign of very, very heavy end-stage chronic heart failure of the left side especially. And now I will show you the special stain that will highlight all the iron that is within this slide. If I recall correctly, the special stain was performed on the same slide. No, it's a different slide, I apologize, but still it's nicely visible how many macrophages they are. All the macrophages which are blue, they contain the hemosiderin pigment, which previously used to be brown, but due to the chemical reaction with the pearls, Prussian blue iron stain, they turned blue. You also see that some are black. This is anthracotic pigment, well, because since we are in the lung, here's a bit more carbon pigment here. So this is just simple anthracosis. So what you see here is a combination of plain or simple anthracosis plus brown induration or hemosiderosis of the lung. This is once again, I recapitulate, a sign of chronic heart failure. and these people may cough up sputum containing iron-laden macrophages. So let's move on to the next one, chronic venostasis of the liver. This is also called the nutmeg liver. That's the macroscopical picture. Just Google what the nutmeg looks like. And somebody thought that the liver affected by chronic venostasis is very similar to a nutmeg. And this condition develops when you have chronic heart failure, especially of the right side, because there's chronic venostasis within the liver as the blood isn't transferred effectively enough, isn't drained from the vena cava inferior to the lungs into the heart for some reason, usually due to failure of the right side of the heart. It could be due to pulmonary hypertension and so on. You learn about this in pathophysiology a bit more. Now I'm just concentrating on the morphological changes. So let's have a look at it. It's quite a characteristic picture. You usually see it in low magnification. You see that it's liver. You can see the central vein. No, sorry, it's a big portal triad. Yes, it's a big portal triad. If I zoom out, I can see that sort of there are some areas which are a bit more red. These are the areas which are engorged with blood. These usually tend to be centered around the central veins. So you can see that we have areas which are engorged with blood. This will give the look of the nutmeg in macroscopy. If I zoom in a bit closer, here you see the portal tract, and here you see a lot of blood within the dilated sinusoids. Here you see a central vein, and it's centered around the central vein, which is appropriate. And you see also one more thing which you should recall from the previous lecture. Here you see steatosis, mostly of the macrovesicular type. Here we don't see the steatosis because this person is drinking alcohol. This person might have drunk alcohol, but I don't think it's that. This change happens because due to chronic venostasis there are metabolic changes. There is metabolic deprivation within these hepatocytes, and the stereotypical way that the hepatocyte reacts to this kind of metabolic damage is by doing steatosis, because the free fatty acids and triacylglycerides start to accumulate in them. This is a sign of chronic hypoxia. As you know, in order to metabolize fatty acids, you need to perform the so-called beta oxidation, and this beta oxidation is highly oxygen intensive. So if you have chronic hypoxia around the central vein, then logically this reaction will not be able to move forward, and the metabolites, the triacylglycerides and free fatty acids will accumulate, leading to steatosis. This is in a nutshell why the free fatty acids and triacylglycerides accumulate within the hepatocytes. So this is one more reason for steatosis. There are many others. So once again, just a recapitulation, nutmeg liver due to chronic venostasis. You see the tracts of venostasis within the sinusoids. You see a lot of blood cells, and this is something that we typically see in chronic heart failure of the right side. So this should be understood by you. We ask this a lot. So let's move on to thrombosis. Just very briefly, some theory. So thrombosis is when pathologic coagulation occurs within the lumen of the vessel wall. As you know, coagulation is very important physiologically to stop the bleeding. So if you have injury to your endothelium because you tore the blood vessel for some reason, then the fibrin mesh needs to develop through the coagulation cascade. This is the super glue which will glue the vessel wall so that you don't lose blood. Blood is very important for the organism. It contains a lot of proteins and nutrients. You don't want to lose any of it. It's not good. It's a waste. So your blood vessels, they need to stop the bleeding by regenerating their vessel wall. If the endothelium is injured, then the coagulative cascade is started. You remember it probably much better than I do. So you might be able to revise it if you feel like. You probably have to know some of it for pathophysiology once at least, so that's on you. But now to thrombosis. So thrombus develops if this is a pathologic process. Well, you should be familiar with the Virchow's triad, which are the three components of basically the triad of factors which can lead to thrombosis. And these three components are injury to the endothelium, change in blood flow, and change in the coagulative capacities of the blood. You can read about this a lot in theory, so I suggest you to do so. Now we will be discussing mostly morphology. So let's move on to the next slide. So here we see a big vein. You can probably guess that this big vein is maybe a popliteal vein, maybe a femoral vein from the lower limb. That's a place where usually you get thrombosis in people who are bedridden. So this is something that you're going to be always mindful of when you are treating your patients. So this big vessel, this big vein is filled with some kind of material. You see it's mostly red, but some parts of it are pink. The pink parts, those are the fibrin mesh. This fibrin mesh in the fresh thrombus holds the whole thing together. It trapped the red blood cells, it trapped the white blood cells, and it developed into a structure which has managed to totally block the lumen of this big vessel. So this patient is going to have some symptoms on that limb, but they don't have to have any symptoms at all. There might be unilateral edema, there might be pain upon walking, but there might be nothing. So here we check out the fibrin mesh. Fibrin is pink, is deeply eosinophilic, mesh-like. You see fibrin working as a super glue, but unfortunately in this case it has managed to clog up the entire vessel. I suggest you to check out the theoretical part about deep venous thrombosis. I made an audio lecture about it, so you should have a clear idea why this happens. Is one of the ways that you can kill your patient if you don't pay attention. So if you're not going to know it flawlessly with me, then you're going to have trouble during the exam. I can guarantee you that. So a fresh thrombus consists only of fibrin, because thrombi, they have a life cycle that I will talk about. So just very briefly, a thrombus, it develops, it's still fresh. So what can happen? The best thing that can happen to it is that either it dissolves by itself, or we dissolve it through pharmacological means. If it doesn't go through pharmacology, we can perform catheterization. So we can remove the thrombus mechanically with a thrombectomy. This is also sometimes done with a fresh thrombus. So we have several options how to attack a thrombus which is fresh. So let's talk what happens to the thrombus later. One thing which can happen are different forms of organization. Let's move forward and let's talk about organization. So you see, it's very similar to the one that I've shown you before. You have the fibrin mesh, you have the entrapped blood cells, but if we look at the periphery, we see that something's going on. So now I'm showing you where the intima of the blood vessel is. Here you see the media, this is a big vein. Once again, here's the line of the intima, and here you see that there's something sitting on the intima, something which has a lot of blood vessels. So this is highly cellular collagen and blood vessels. This is the so-called granulation tissue. We also call it non-specific granulation tissue. This tissue, this is the universal scaffolding that you see when something is healing. So whether you have a scar which is developing after an infarction, after necrosis, or whether you have a healing wound, whether you have a thrombus in organization, you have non-specific granulation tissue. This is the first step in a healing. because the fibrin needs to be removed. Here we have the fibrin. You see the eosinophilic mesh-like material entrapping the erythrocytes and the white blood cells. And as we move towards the periphery, towards the intima, the fibrin is being supplanted by non-specific granulation tissue. Here in this area, the non-specific granulation tissue is fully developed. And here in this transitory area, just the blood vessels are growing into the fibrin mesh. So here we still have the fibrin, but it's starting to be surrounded by blood vessels, and gradually the fibrin is taken over. So if I zoom out, you see that here the organization is starting at the periphery and it hasn't progressed all that much. So this thrombus might have existed for maybe 2 weeks. So it's going to take logically months until the entire thing turns into granulation tissue or scar tissue. So one of the fates of a thrombus is turning into scar tissue through organization. Naturally, the organization can be only partial, so you can have the so-called recanalization. In this case, parts of the thrombus can become patent again, so the lumen of the vessel will be smaller, but you may have a different neolumina through which some blood is flowing. This is another possible fate. Or if the thrombus has completely organized, it can also calcify. You see this in varicose veins of the lower limb. These are the so-called phleboliths. You see it in the lower limbs of in varicose veins, or you can see it in the venous plexi of the uterus, prostate, and so on. So sometimes the organized thrombus, this tissue here, can turn into scar tissue and organize, and then calcify, and through dystrophic calcification, you might get phleboliths. So let's check out another fate of the before we jump. Another type of thrombus is the so-called mixed thrombus. We just show it to you because we think it's nice. So they say that a thrombus can develop in the arteries and also in the veins, and in venous thrombus, which develops over a certain time, you can have these lines of different consistency, lines where you have more and less fibrin and inflammatory cells. On macroscopy, these are the lines of Zahn. Z-A-H-N, lines of Zahn. This is just something nice. So this developed in a big vein, most likely. And this is just gradual development of the thrombus layer after layer. This is still a relatively fresh thrombus. So now let's move on to the more important thing which can happen to a thrombus. One of the potential fates of the thrombus is embolism. Embolism means thromboembolism. You need to always call it thromboembolism because other materials can embolize as well, but that is beyond the scope of this lecture. So back to thromboembolism. A thrombus forms in a certain place, let's say a thrombus in the vena femoralis, in your femoral vein. So in order for it to become an embolus, it needs to detach. At least part of the thrombus needs to detach from its mother thrombus, from its origin. So as it detaches, it becomes free floating within the blood. So it's carried within the bloodstream logically into the lungs. So 99.9% of these end up in the lungs. Very rarely, if you have an open or a patent foramen ovale, then it can end up in your systemic circulation, usually going into the brain or anywhere else it feels like. So this is the most important way a thrombus of the lower limb can endanger the patient's life. Remember sequence: thrombosis of the deep veins, then detachment of the thrombus, an embolus is formed which travels into the lungs and which clogs up part of the pulmonary artery. If this thrombus that has detached, if this embolus is large enough, it can cause instant death. Immediate death. These are the so-called saddle thrombi because they get stuck at the at the bifurcation of the pulmonary artery, where the two branches come out from the truncus pulmonalis. So So this is instant death, nothing to do. More frequently, they just block up a big lobar or segmental branch of the pulmonary artery. In this case, the patient will be complaining of sudden onset of dyspnoe. And in this case, you need to be very attentive because you can still save the patient if it's early enough through thrombolysis. Another scenario which can happen is gradual detachment of thrombi, which are smaller over a longer amount of time. This is the so-called successive pulmonary embolism. In this case, there is gradual loss of pulmonary function, and this can be quite insidious. So let's have a look at the slide. Remember the theory, this is extremely important for your future as a doctor, if you want your future to be outside of the prison and courts. So here we have a case where the thrombosis has happened. Here's a relatively fresh thrombus. We check for organization, if there is any. There is a very minimal organization at the periphery. So the patient has, here there's some little organization. So the patient has survived, let's say maybe a week with this thing. The patient has survived a little bit, but here is the organization. Here you see the blood vessels growing into the fibrin mesh of the fresh thrombus. So this patient has survived for some time, but unfortunately the patient has died of it. Well, in many patients you're not going to be able to prevent the thrombosis, but every attempt should be made. And in case there's some problem and some death or great damage to the patient, then the lawyers will check what were your measures against thrombosis. So please don't forget this. I will make sure you don't. So here you see thrombotic embolism into a big branch of the pulmonary artery, leading to patient death, unfortunately. So let's move on to the next slide. Hemorrhagic necrosis and lung infarction. So you might ask yourself, how do we get infarction of the lung? Do we get the infarction of the lung after pulmonary thromboembolism? The answer is that we don't get lung infarction every time. The secret to this is that the lung has a dual supply of blood. There is one system which delivers oxygen, which comes from the pulmonary artery as it's oxygenated, so the pulmonary functional circulation, but also you have a nutritional circulation which comes straight from the aorta and which supplies the bronchial tree with fresh blood from the aorta with nutrients. So in order to get a lung infarction, you need to have a compromise in both of these systems. And a combination which you might see is a recent thromboembolism plus chronic heart failure. So you need to have something like this, or a hypercoagulative state. So in most patients, even in those who had a very big pulmonary thromboembolism, you're not going to see lung infarction. You need something more to it. In this case, this is going to be a very nice case, as you will see. So you start by small magnification. Here you see that there is some part of the lung with a very heavy edema. You can see the edema fluid within the alveoli immediately. And then you see another big area which is full of blood, which is extremely hyperemic. We zoom in. You immediately see that there's some kind of thrombosis here. There's some kind of thrombosis here. So there are thrombi in multiple blood vessels. So I'm going to guess that this person had a hypercoagulative state, because if we zoom a bit closer, here we see the edema, but we see that there's something else going on. You see these strange cells? They are not in blood vessels, they are in lymphatic vessels. So we see these very strange cells. We go a bit closer, see that they have very big nuclei, they look very ugly. Here they are forming like glands. See, they are forming some strange gland-like structures. So these are lymphatic vessels and they are full of adenocarcinoma cells. So this patient had a stage 4 adenocarcinoma. I don't know exactly the history of this patient, but here I see a psammoma body, so I'm going to guess this was from the ovaries. So this was probably ovarian cancer. This is just my guess. This is an autopsy case. So this patient had a very, very heavy pulmonary lymphangiopathy. So this has damaged the lung, and if you have a cancer, then in many cases you can have hypercoagulative states, so you are you're much more prone to thrombosis and thromboembolism. So this patient was at risk, and due to this very heavy hypercoagulative state and thrombosis here of these branches of the pulmonary artery, this patient developed a lung infarction. If we check out, you see that this is a hemorrhagic infarction, which is a subtype of coagulative necrosis. You see that there is very, very heavy hyperemia. The blood has totally engorged the alveolar spaces and everything. This is relatively fresh and everything is already dying. So this lung infarction happened quite recently because the cells haven't lost their nuclei yet, but they are on their way out. Here you see some leftover ghostly outlines of the alveolar septa. So lung infarction, remember, you need to have multiple pathologies for this to happen. One is not enough, and not every case of pulmonary thromboembolism leads to lung infarction. Remember this. So this was a very nice case. Let's move forward. So now we are going to talk a little bit about atherosclerosis. If you recall my last lecture, atherosclerotic or Atheromatous plaques have a very long and complicated life cycle. They start as fibrous plaques which contain only collagen, or as fatty streaks which are very low, just a horizontal, very flat lesions containing some foamy macrophages. So you, in your age, you're already starting to have some fibrous plaques and fatty streaks. It starts at an early age and gradually they develop. In males, the development of these plaques is more rapid. The females are safeguarded by their estrogens and progesterone, but once they run out of these hormones after menopause, they will catch up with the males in regards to complications of atherosclerosis. This is a very important disease which kills most people in industrialized countries. It leads to many different organ damages. The most important is ischemic heart disease and heart attacks. Then strokes are extremely important, ischemic strokes. Then you can have infarctions in other parts of your body, like infarctions in the kidney infarctions in muscles, infarctions of the bowels. That is extremely important, and so on. So multiple organs can be affected. So atherosclerosis is essentially a systemic disease. So let's check out some plaque morphology, because some plaques are more dangerous than others. As I've already mentioned, the small plaques, the fatty streaks and fibrous plaques, they are essentially harmless. The dangerous ones are plaques which are calcified and which contain a lot of fat. So this sample, it comes from the lower limb, and this patient had ischemic disease of the lower limb, which is a very unfortunate form of atherosclerosis, in which you have critical ischemia due to atherosclerosis affecting the big arteries of the lower limb. So these people, they cannot walk all that much and they have extreme pain. So let's check out the atherosclerotic plaque. Here you see the artifact. There was a lot of calcification, which has been cut by the microton blade. If you have calcification, it's very difficult to cut. And we check out the atherosclerotic plaque. The atherosclerotic plaque was big like this. It's almost circular, and it was almost completely occluding the lumen. One of the things that we see here is that there are blood vessels forming within it. There are a lot of foamy cells. These are foamy cells here. So it contains a lot of fat. it contains granulation tissue, and it contains a lot of newly formed blood vessels. So this is an unstable plaque. The more fat the plaque contains, the less stable it is. Here we see a lot of foamy macrophages once again. Check out the cytoplasm of this. And we see also some cholesterol crystals. So this is a very unstable plaque. And here we see some areas where there was fresh bleeding into the atherosclerotic plaque, most likely from these newly formed blood vessels. So if you have bleeding into the atherosclerotic plaque, it can lead to its sudden enlargement, and this can block the lumen of the artery. Especially prone to unstable atherosclerotic plaques are the coronary arteries, and it can lead to very rapid closure and to heart attacks. Basically, so here you see this is a textbook example of an unstable plaque which has suddenly enlarged due to bleeding into the plaque, and it has caused critical ischemia, which has led to the loss of the limb. And let's check out, I think, the last slide. Calcified atherosclerotic plaque. So this is a different type of plaque. So in this case, the changes happened very gradually. Once again, it's all mangled because these are very hard to cut. So now I'm just outlining more or less how the blood vessel looked like this. This is an artery, and here you see a massive plaque, which is mostly fibrous. Not a lot of fat here, and we see huge areas of calcification. You see here it has all calcified. So this plaque also has managed to plug up the entire lumen of the artery, just like the previous one. But here the good thing is that these plaques develop quite slowly. So this probably has taken years to plug up the lumen, not just a few days as the previous one, or maybe a few minutes if there was big bleeding into it. So these plaques develop much more slowly, and this means that the organism has chance to build up collaterals. So if you're really lucky and you have a completely clogged up vessel, but you have managed to develop the collaterals, then you don't have to essentially suffer critical ischemia of that limb, you see. So the dynamics, the rapidness of the closure of the arterial lumen is also very important. In general, we say that critical ischemia develops when at least 70% of the lumen is closed acutely. But in some cases, if the closure is very gradual, even in the coronary arteries, you have enough time to develop collaterals. So this patient might have had a milder course of the disease. Naturally, this is also from a lower limb. So in this case, the ischemic disease of the lower limbs has also led to loss of said limb. But just understand that not every atherosclerotic plaque is the same. Some are less stable than others, and each is dangerous in different ways. So this was all for this lecture. Thank you a lot for your attention, and see you at the next one.